I'm audible. Okay. We are working on this last 1.5 years, collaboration with University of. Can I have my slides to be displayed here? So why this project? Why we are talking about a need of home or emergency monitoring of something called international normalized ratio device? Why we need it? So the thing is, we have a heart. There are four valves in that, and this heart valves tend to become disease. They may leak or they become very short. If that happens, because of these various reasons, if that happens, we have to replace these valves. And how do we replace these valves? One second, I just pointer. How do we replace these valves? The commonest is we replace with them with this metallic valve. You can see there are different kinds of metallic valves. And whenever this metal comes in contact with our blood, normal flowing blood, what happens? Blood tends to coagulate or forms a thrombus. So if this forms a thrombus, what will happen? This valve stop working. This stops working, the patient will not survive. So any patients you put a metallic valve in any of this one of the place, they should be on something, a blood thinner. So if you don't put them on the blood thinner, you can see this uh, clot forms there. So this is, and the incidence or requirement of this replacing a metallic valve is actually very high. We have a lot of patients who are on these kind of valves. It may be different reasons. Young patients because of rheumatic heart disease, older patients because maybe sclerotic disease. This is next. Now the medical sciences, there is a huge evolution in the medical science. So if our heart starts failing, what do we do? If the medical therapy fail, what do? We do heart transplant. And if you're not doing heart transplant, we give assist device. In a layman or simple language, you can say we give artificial heart, which takes away the load of the heart. So it's a left ventricular assist device. So blood comes in into this pump and it rotates and then it throws away into your aorta, and that's how it takes away a lot of load of a failing heart. So if any patients I put this in, this is a very costly device. The cost of the device is more than 50 lakhs actually per patient. So now we have a lot of patients who are on LVAD now, and the number will keep on increasing in future. So again, it's a big metal you're putting in the heart. And for now, if I put this patient on this device, they again need a blood thinner. And for now, in a medical science, the only blood thinner, whenever there is a metal inside the body, is available for us is vitamin K antagonist. It's called common language warfarin or acetrom. And when you put the patient on a blood thinner, they need a particular value of INR. And even for surgeons, like if the patient is going for big surgeries, you feel that liver disease is there, we need to monitor INR. So the therapeutic value of INR is simple value 2 to 3. If the value is less than 2, that means this drug is not working and you have to increase the dose. If value is more than 3.5 or 4, the chances of bleeding is very high and the patient can start bleeding from any place. And and how frequent do you need the monitoring of the INR? This is a real world data from our cardiology OPD. So in my cardiology OPD, where we are doing meticulous monitoring of the INR, like every month, patient comes, you take a sample and you check the INR. And when you check INR, despite of patient coming to you very regularly, only 50% of the time the value is in a therapeutic range, which I'm talking about, between 2 to maximum 3.5. And if you can see that more than 50% of the time, or almost 50% of the time, value is either low or high. And what does happens when this is there? So why does this happen actually? Because this is vitamin K dependent antagonist, it has a lot of food interactions. Anything you talk about, you eat in your daily life, any green leafy vegetables you eat, because all our Indian food, like we put green leafy vegetable, coriander or curry leaves or anything, any green leafy vegetable you start with, sprouts you start with, or there are a lot of meat products or a lot of dairy products. I don't know how much to restrict patient to restrict this food. Understand, as a daily. So it becomes very, your INR is not in the therapeutic range. And not only food interaction, this drug has a lot of drug to drug interaction. So especially for cardiologists, our patients gets admitted, they receive amiodarone. The INR will increase drastically. And if the patient is receiving something called digoxin, is a common drug, INR will drop down drastically. So there are a lot of antibiotics. If the patient is on acetram, he or she goes out, develops some fever, you start fluoroquinolone, your INR will go up. And if this happens, what is the thing? This is a dreaded complication. Comes to you with the bleed. So they'll come unconscious. Whenever patient comes to you unconscious and you know there is a stroke and patient is on acetram, you don't know whether the stroke is because of bleeding or thrombus, right? To make it sure, to do anything, you send patient for CT and then you do an INR. And how much time does it take for the INR value to come back to you? You take a sample, you send to emergency and the report comes. It takes 2 to 3 hours and you're till then waiting. So and there are a lot of complications. For example, patient comes with the breathlessness and there is a stuck valve. And you want to start blood thinner for that. And you have to wait for the INR value, because if INR is very high and if I give high doses of blood thinner, patient will bleed here. So there are a lot of practical issues with it. So that's the reason you're thinking about why not to have an indigenous machine, like a point of care machine, where you just take a pinprick and your INR value comes in 8 to 10 seconds, right, patient? So this is how you manage diabetes. So diabetes, 3 days, decades before, any diabetic patient comes to the emergency unconscious, we used to think whether it's a severe hypoglycemia or hyperglycemia. So used to send sample and it will take 3 years. But now patients are become very powerful, diabetic patient. They check sugar at home. They know already that whether the sugar is high or low. So it's a simple device, point of care device, where patient knows how to manage. They can increase or decrease their dosage. So same thing, same thinking going on. Like, can we have a point of care machine where patient at home can monitor INR, adjust dosages, because sometimes patient eats outside or patient has a small swelling in the knee, it's a hematoma, you know how much is the INR. For example, if INR is a little high, you can tell patient eat green leafy vegetables so that your INR gets settled. Or if patient checks INR at home and it's low, you can say that increase your dose and patient can monitor. At the same time, patient comes to the emergency on acetram, or patient is having some liver disease, you want an INR to operate the patient. And if you have a point of care machine available in your emergency, you can take a decision very quickly. So that's what the thinking process is. Although this INR devices are available, they are FDA approved devices, but we don't have an indigenous device. So that's the reason we thought, like 1.5 years back, with the help of Sasikala madam, I spoke to her about this device. So can we have, so this is the objective, is to manufacture this device and then to test the efficacy of the device with a standard laboratory machine. So first stage is, that's why we took help of University of Hyderabad, Professor Ghansham and his team, so that they can help us manufacture this portable battery operated instrument, which can give you a PTINR value within seconds and you can take decision. And once they manufacture the prototype in the institute, we can check the efficacy or how it is working. So in the stage 2, we thought that once this device is available, we can check it with healthy volunteers first. And then once we are sure that your machine's efficacy is good, you can check it on the patients who are on vitamin K antagonist. So I'll stop here and I'll invite Ghansham sir to talk about the project, because the maximum work, this is what the thinking process, 90% work has to be done by them only. So all the challenges they have to face. And invite Professor. Thank you very much.
Uh, Good afternoon. Thank you for this opportunity to the AIG team for talking about the development of the sensor, which we are been doing for about 18 months or so. So there are two parts to the presentation. I will just give you an overview of what sensors are and why we are doing it the way that we are doing. and our student Udaya will talk about technical details of work that has been done now. So my name is Ghanshyam Krishna, and my colleague Professor Sabat is here. We are both professors in the Center for Advanced Studies in Electronic Science. Just to give you a 1 minute background of us, each one of us, I am a physicist by training. My PhD is in instrumentation and applied physics from Indian Institute of Science, and Professor Sabat is by training an electronics scientist, and he has a PhD from Berhampur University. We have been in the University of Hyderabad for over 20 years, I think. And my areas of research have been materials engineering, development, nanomaterials, and sensors. And Professor Sabat has been working on the signal processing, VLSI design, and things like that for, among other things, sensors. So we have made some sensors, which this is just to flash one slide, uh, not related to. So we have done, we have made some ammonia sensor using polyaniline. We also looked at nanostructures for detection of explosives. Sabat has worked on the signal processing and the early detection of cardiovascular diseases using some electronics. Of course, we can answer questions if you have later. So, so I'll just briefly, with apologies to all the experts in the audience, just to set the platform for what we're going to talk about. So sensors essentially are devices that respond to an external stimulus, uh, which is which could be a chemical reaction, it could be a physical interaction between the uh, material and the environment, and it gives you an output which is sort of related to the input. So these are essentially, this is what a sensor is. And uh, the output is generally a signal that is converted into a readable display, and the sensor signals can also be transmitted, over the network. These days all your mobile phones are basically sensor networks. You have so many things: blood pressure, your rotation of the mobile phone, the latitude of the earth, the magnetic field, uh, all kinds of things are being monitored. So you have smartphones, which are basically sensor networks. Now, so there is a classification of the sensors based on four parameters, which is essentially the primary input quantity, which is what you are trying to sense. And then the principle of transduction, which is essentially involves the electronics, this is signal processing, and so on. So it could be a physical input, it could be a biological input, or it could be a chemical input. So, for example, the gas sensors that you see in various places which are monitoring environmental pollution, they're basically chemically reacting with the surface, which is typically a tin oxide material. And the chemical reaction induces a change in resistance of the tin oxide. And that change in resistance gives you an idea of what the level of concentration of these polluting gases are. So, uh, so therefore, you need to know what kind of materials can actually uh, involve themselves in these kinds of sensor behavior. So, material property and technology is an extremely important and integral part of the sensor development. Of course, you also need to look at the applications. For example, what we are doing now is the sensor to measure a particular quantity. Now, there are several steps in the development of a sensor. The first is, of course, you need to know the physical principle based on which you're actually trying to develop this. So I'll give you a very simple example in the next slide. So you need to know the physical principle. Then you have two measures. There is a quantity that is being that is the input, and there is a quantity that is the output. Now these two must have a correlatable relation between each other. So it has to be a mathematical equation which relates the input to the output. Now when you do that, you have to then what is called linearize the relationship. So there are many relationships between physical quantities which are not linear. So, for example, if you take thermal expansion of material, it goes as square of the temperature. Resistance goes as to the power of 1. Now, when something goes as square of the measurand, then you have to linearize it and then electronically extract it. Once you do this, then you have to find a technique which need measure the output. Now, these are all the parameters, as Dalit Madam said. These are actually all the challenges, the response and sensitivity, how fast uh, can sense the parameter, the selectivity. For example, in the presence of different kinds of, in an actual environment, there will be many other chemicals that are present. Now, does your sensor respond only uh, to the input that you're interested in? So that is selectivity. Then it has to recover. There's no point having sensors which are one-time use. So that becomes very expensive technology. They have to recover and they have to be reusable. So this is another challenge that we have to do. Then reproducibility. Do we get the same result every time we measure? There can't be errors, especially in the context that we are working. It can't be that one time we are getting a value of 1, the next time I measure, because of some interaction, the same person is showing a number which is 3 or 4 or something. So it makes a difference between intensive care and probably home care or whatever. So that is so this actually I had a discussion with, just a digression, if you don't mind. My father was in the ICU about 4 years back, just before he passed away, and they were monitoring the oxygen using this what is it called, the oxygen sensor that we all use at home now. So I asked the doctor. So you know the principle. It measures the intensity of reflected light that goes through the blood and comes back. Now, it measures the oxygen saturation. My understanding is that if the saturation is below some 90%, he was 96 years old, and if the saturation is below some 90%, then it is a matter of whether he should be in the ICU or in the room. My question to the doctor was, if there is a 5% error in the measurement, does your decision change? I mean, I'm not, don't want to be critical, but the point was that the doctor hadn't thought of that kind of an error. Now, that makes a difference between, in some sense, life and death. Now, we cannot afford it in these kinds of measurements because you want to have a reproducible number within a certain error which is acceptable to the medical profession, because they have to take the decisions. For us, it is very easy to make a sensor which has an error of maybe 5%. But is that acceptable? Therefore, reproducibility is a very important point that we have to, once you've done all this, which takes sufficiently long time, then you have to build the interface electronics. So once you have a physical signal, the electronics has to convert it into a readable signal, and then you get a display. So this is essentially the development of a sensor in its entirety, meaning any sensor that you see in the market would have gone through all this. The critical part for you to remember, basically, that the selectivity and the reproducibility are extremely important. Now, for every input that you have, there are many principles come to. So this is a very simple thing. This is a very daily life example. You have to go back to your 12th class, I suppose. The resistance of a metal increases with the temperature. Okay. Now, if you plot, it's very easy to measure the resistance of a metal. You take a wire, you heat it, put a multimeter, and you will get a voltage output. V by I will give you the resistance, and you know what the temperature is. If you plot a graph between the resistance change R versus T, you will get a straight line. Slope of the graph is basically the sensitivity of the sensor, right? So you have made a sensor by simply heating a copper wire to a certain temperature and measuring the resistance versus the temperature. Now, how does it become a sensor? The graph has a slope. Slope has the units of ohms per degree. Okay, so if I have an unknown material which is measuring 50 ohms and I want to know the temperature, I multiply by the slope and I will get the temperature. So You can make this at home. You basically heat any wire, measure the resistance, and you will get this. So this is basically, in its simplest form, the development of a sensor. Am I taking too much time? I'll only one more slide. So now in the project that we are doing, we had a variety of physical principles, I will tell you, which would have based the sensor. Why did we choose electrochemical impedance? So electrochemical impedance is essentially an electrochemical cell is a battery we have used there. It has three electrodes, anode, cathode, and an electrolyte. When you apply a potential, because of charge transfer through the electrolyte, there is a flow of current. Now this flow of current multiplied divided by the voltage will give you the resistance. At high frequency, it is called impedance. Now this impedance apparently changes linearly as a function of your whatever is happening during the clotting procedure, which she will describe. And therefore, the clotting time is a function of the that you are measuring. Now, why did we choose this? Because there are other methods like optical methods and mechanical methods and other methods, but this is the only method which is amenable to miniaturization. Because you're looking at a point of care, uh, point of care application, you need a small box, which, as Madam said, like a glucometer. Now, no other technique can actually allow you to miniaturize the product. This is the only one because you can have small electrodes, which is like a strip of the glucometer. You can put it inside a box and you can reduce the size to something like this. Now, this is why we have electrochemical, even though it is possible that there are other techniques. Now, I will stop here. If you can answer, or we'll end the session, then we can. Then I will ask Udaya to tell. So, I acknowledge everybody who is, before I forget, I'd like to acknowledge Dr. Haripal, who, Madam, listened to us. He introduced us to. We have learnt a lot, and the hope is that we'll produce a. Hand it over to Udaya for the next one.
Today, I wish to share with you our details of our project in designing an indigenous device for point of care estimation of prothrombin time. So this will be the outline of my presentation. First, we will briefly look at the mechanism of blood clotting and need for the assessment of PTINR. Then we will look into why we have chosen impedance-based sensor, and we shall discuss the results and challenges that we have incurred so far. So as Daljit Madam has discussed previously, warfarin is the drug at the point of question at this point. So monitoring coagulation pathways becomes crucial in subjects who are prescribed warfarin or other similar anticoagulation drugs due to their potential risk of heart stroke. Warfarin basically is a vitamin K antagonist which inhibits gamma carboxylation, which also inhibits the production of factors 2, 7, 9, and 10, which are essential in the extrinsic pathway of blood coagulation. However, warfarin does have a very narrow therapy, meaning the two is in in fulfilling its purpose, while too much warfarin may result in bleeding anomalies. This raises the need for monitoring PTINR regularly. So the objective towards this project is to develop a cost-effective indigenous PTINR measurement system based on electrochemical impedance spectroscopy. I will brief you shortly with the existing techniques of measuring prothrombin time. First is the classical method of using a mechanical technique to meet PTINR. In mechanical method, we basically have a metallic ball placed inside a plasma sample. The ball is subjected to oscillations of certain frequency. As the plasma sample clots, the oscillations of the ball tend to dampen due to the external resistance that occurs. So this dampening of the oscillations is translated into the Next method is optical method, which is by far the most widely used method. So in optical method basically exploits the fact that a plasma and a clot of plasma have different ways that they react to the transmission and refraction of light. So the transmission and refraction of the light are assessed using optical sensors placed strategically across the plasma sample. Next is acoustic based sensors. Acoustic sensors are basically quartz crystals. Quartz crystals have a natural frequency at which they tend to oscillate when subjected to a stimulus. However, when placed in plasma and plasma clots, the crystal faces an elevated amount of resistance to its vibration. So this causes the natural frequency of vibration to shift by certain level. And this shift in frequency can be seen as the time of clotting of plasma. The next method is the electrochemical. So in electrochemical method, we have direct and indirect, in which the process can be held. So in indirect method, we are looking at the formation of thrombin. So whenever thrombin is formed, we have very sensitive receptors binding to the formed thrombin in the sample, and whenever fibrin is converted to fibrinogen is converted into fibrin, we have different particular peptide substrates that detect the clot. The method that we are presently using is the direct sensing method. So direct sensing method is simple to understand and simple to. So the fact is that whenever a plasma clots, there is a different the unclotting plasma and clotting plasma exhibit different electrical properties. This table shows all the existing PTINR devices for point of care application. These are in the past decade or so, so many devices have been in market, and only two remain in market at this point. So in this slide, we can see the different places and different devices for point of care device and their INR range that they are capable of measuring, the time that they take to calculate the PTINR, and different their laboratory correlations. So why we have picked an EIS sensor? EIS are sensitive to clotting time. So compared to other sensors, optical sensors are highly sensitive. After optical sensors, EIS sensors are the next most highly sensitive to the clot. Next thing, they're minimally invasive. So we have impedance-based measurements. So they do not require that we draw the blood. Rather, we suffice with a finger prick. Next thing, we have real-time monitoring. So especially in the scenario of operations, it becomes necessary that PTINR is monitored continuously for the period of so in that case, electrochemical impedance based sensors are most viable for such applications. And next, electrochemical impedance-based sensors capable of being reduced in size so they can be portable and cost-effective. So the principal electrochemical impedance is similar to resistance, except for uh, in this case we are using a sinusoidal current signal rather than linear current. So this is a graph from literature that shows the difference in impedance while the clot is forming. So the black curve is a non-clotting sample, and it shows a monotonous drop in the slope. However, the red curve, which is clotting sample, actually shows an inflection at the point, at a certain point, which is the point of clotting. So this is the principle by which we are able to detect the clotting time. So the second part of the slide shows. At this point, the question is impedance depends on the frequency of operation. Which frequency of operation do we pick to determine the impedance? So we have gone through the literature and we have looked at different results. So we tried 1 kilohertz and 10 kilohertz, 25 kilohertz, 50 kilohertz, and we found that anything between 10 to 50 kilohertz is giving a good inflection to be noticed. From this point, we moved on to uh, building a device. So on the right side of the slide, we can see the presently used machine, which is Roche Coagucheck X. So the present cost of this machine is 32,000. Each strip would cost about 250 rupees. So then the machine that we are trying to develop is based on a microcontroller called ADUCM355. So we built a interface around the system, and we are presently using a PTINR strips from a company called QLabs. So I shall discuss the results that we have. So first question was whether our machine was able to detect the clotting or not. So on the left side we have non-clotting plasma, that is citrated plasma, and on the right side we have capillary blood samples. So we can see that non-clotting citrated plasma do not show any drop in the impedance as the time proceeds. If anything, they show a rise in the impedance. But while at the same point, at the same time, the clotting plasma do show a dip in the impedance curves at a very particular point. So these are repeated readings on the same sample, and they tend to show a dip at the same point of time. So from this, we understand that the results are consistent. And the next question that we are facing is whether the instrument is calibrated to has the same accuracy as the gold standard impedance measurement system. To determine that, we have used in gold standard measurement systems already available in the university. So we would take the same sample, do it on the present system, we measure impedance while it clots, and same sample we'd measure the change in impedance using using a desktop workstation. So we had convincing results that we are able to verify that the accuracy of the present system is as good as that of the desktop machine. So we know that we are able to calculate impedance properly and that we are able to detect the clotting point in the samples. Next point, we have moved on to use the QLab strips. And at this point, in our initial trials, we have discovered that there is a problem with the electrical contacts and also the temperature instability. The PTINR has to be measured at the body temperature, which is has to be with 37 degrees Celsius, while the room temperature can be different at different points of time. So we had the necessity to stabilize the temperature and stabilize the electrical contact. So we moved on to integrate an PID temperature control into the device to keep the temperature stable at the measurement temperature of 37 degrees. And we also integrated a well-tailored electrical contact at its chip reader to have better results. And from this point, we moved on to perform tests on the normal and abnormal normal control plasmas. So when we have looked at the control plasmas, we were we know that the plasma is expected to clot between 10 and 15 seconds. Uh, we have we were able to um, recognize and point of inflection around that window of time. So from this trial, we are able to understand that once the temperature is stabilized and the electrical contact is stabilized, we are able to detect the point of clotting visually. So from here, we went on to perform a very short clinical trials with about 10 subjects. So these are the 4 readings belonging to the same subject. So we can see, so the green in each set of readings, the green line shows the point of time when the sample is introduced into the system, and then the pink line would show the point of clotting. So, so visually inspecting, we are able to understand and recognize the point at which the blood sample is being clotted. And from this point, instead of visual recognition, visual inspection, we would like to replace the visual inspection by an algorithmic inspection. So we adapted this. So we adapted this method of calculating the slopes of curves. Uh, at a, so these are the same readings, but the slopes of curves are the same readings that we previously seen. Once we are determining the slope of each curve, from this slope we are able to detect the point of clotting without intervention of a human, simply by using an algorithm. So this is the point at which we are right now. So the challenges will be discussed by
Dr. Anand, thank you, Uday. I believe it is now clear where we are. The journey was not so smooth, right? So we are still, we got some result now, but we have to still validate with so many instruments and so many subjects. The main challenges what we are facing till today is stabilizing and validating reagent under room temperature, because we are using now QLab strips. Using QLab strips, we are doing this measurement. The question here is how we'll replace the QLab strips, and can we make our own strips? That there, since we belongs to all same types of background, we are facing problem of finding suitable collaborator who can help us to do that strip design. The other thing is is the whole results, whatever the impedance results we are looking at, we have to compensate these results, but the result changes with temperature and hematocrit and sedimentations. Also trying to build a compensation algorithm on that, by which the result will. And once we have this, again integrating all this field trials, it has to be done. That also will take time. The main problem what we are facing till now is, or as of today, is how to make the strip label and the chemical which need to be put into that strip so that we'll get the PTIN value correctly. Any other?
So the summary is that we are able to say that the blood is clotting around 10 seconds. That is very clear from our measurements that we have made. The point is that the thromboplastin, I think, is the reagent that is being used, that has to be stored below room temperature. And it is also expensive. So the question is, can we find a reagent which can do the same job but need not be stored at in a fridge? That is the other question that we are trying to find. Third question, when we do the integration, there will be other kinds of problems like mechanical integrity, uh, signal processing, and so on. So unless we make the box, we'll not be able to. But from our instrument, we are able to say that whatever the Roche machine is saying 10 seconds, we are also getting 10 seconds. That of concept of the physical established. So this is where we are, and we're happy to answer any questions, any queries, or any comments, suggestions. Thank you.
It's actually very exciting to see a device being developed in our own premises. One of the last slides compared the results, and from the same subject, can go back to that. Uh-huh. That much time is not acceptable. Friends. Lot of difference in the
In both slides, we have a reading that starts at 35 seconds and 3 seconds.
not explain that. That's why we're able to
Yes, ma'am.
understand.
We are looking at the window between.
What will go into why I said sorry, the rate change of the impedance. This one is the actual that slope will be converted into the electronics. That is what we have to linearize. And we are at like the curve, we are at some inflection point. We need some biochemistry help and kind of thing. Because I think the hall is full. Main point that I would like to make that all our past efforts were doing materials engineering, and we didn't want to do that in this case because materials engineering cannot be cost effective. So I have done a lot of work on materials engineering for Raman spectroscopy and so on. So what we are doing here is using commercially available cost effective materials, putting them together. That is why the cost will come down. That is our belief. If we start doing process development, then there is no end. And this is where the actual challenge lies. There are not many companies in this country which are actually making these glucometer strips. We've been trying to, somebody can make that, then I think 90% of the challenge will be where we stand. Electronics is ready. That is our view.
Can you articulate a little bit about the QLab strip? The glucometer strip you're using or a
No, no, it is
PTNS?
a PTNR strip. The problem is that uh, O2 machines. So I can't use the Roche strip in the labs, vice versa. And there is an IP issue there, I think. We have not published this, so we are not violating it yet. Put it in a commercial machine that we develop and make a product, we may be violating the labs or the other IP. By indigenous code that strip development is
You also mentioned the reagent that
thromboplastin. That is okay. I mean, that is available in the market, but very expensive. Is there a sort of a phantom for that? Is there an equivalent which don't have the knowledge? We are looking around for that. So one of these things is solved, and they're in business.
and you also mentioned the temperature.
Yeah.
Is that a
These things-
challenge also, or from an electronic standpoint that can be?
No, the electronics we can take a compensation for temperature.
But so little and we
That point. We are now, I think if it's to audience, somebody took the bit successful, we will be able to succeed in making cost dabba, like.
Quite commendable, you have done. Thank you so much.
Thank you. I must acknowledge, I mean, he's been on our back. Otherwise, to leave it to university process, this what we have done in 18 months would have taken 10 years, I think. I must thank Dr. Daljit Madam for some sense harassing us. Sorry, that's just a joke. Just found that's just to one cannot be adapted. Thank you.
Opportunity to make it to life. I don't product has. Thank you very